It's my pleasure to introduce Dr. David Wong, who is an assistant professor and education director of hepatology at the University of Toronto. He trained at the University of Toronto, then went on to McMaster University, where he did his gastroenterology training. He then was a fellow at Harvard University for 5 years and did research in hepatology. He was under the supervision of Dr. Bruce Walker, and he was studying the cellular immune responses in hepatitis C infection. Dr. Wong's other interests include liver disease in HIV-infected patients and development of electronic clinical notes, which we all need in the hospital. He's a recipient of many teaching awards, so I think we're very privileged to have him here today. He's received the Lou Cole Teaching Award for Gastroenterology, the Whiteman Barris Academy Award for Teaching Excellence, and the University Health Network Award for Excellence in Clinical Teaching. He's going to speak to us today about treating hepatitis C and challenges in 2015. And I welcome Dr. Wong.
Well, I'd like to thank you for the invitation and the opportunity to speak in such a beautiful place. My talk is about hepatitis C, and as someone who's been in the field for such a long time, you didn't mention that, I've been at this since the beginning in 1989 when we started using interferon therapy for hepatitis C. Things have changed a lot. So I'm supposed to show you my disclosure slides, and my disclosure only is that I am involved in clinical studies where we use agents for hepatitis C, both in people with HIV and those without HIV. Okay, so let me take you through a few key concepts, because as a hemophilia group, you've heard about Hep C for what seems like forever, since it was first discovered in 1989. You've known about it. There's been a lot of scare and hype about it, and I'm sure you all know people who've become very sick. But at the same time, you also probably know a ton of people who remain well and who likely have been ignoring it for the last many years because you've heard what the terrible treatments were, what the side effects were. People were asking you for liver biopsies. I'm going to tell you about who should worry, who should not worry, and think of it as both an infectious disease and a liver disease. Learn about what's new in Canada in 2015, and there's a lot new. Okay, and then at the end ask, should I be treated now or should I wait? Because some of the therapies for most people, but not all, are pretty excellent right now. Okay, so this is a familiar slogan, that hepatitis C is a silent killer. Well, being alive and breathing oxygen is also a silent killer, right? So you've also been told that people get cirrhosis at a rate of 20% after 20 years of infection, and the risk goes higher and higher afterwards. So you get the feeling that everyone with Hep C will eventually die from Hep C. It's actually not true, okay? I'll tell you more about that. So there is an increased risk, but it's not for everyone. And if you have cirrhosis, there's a risk of both liver failure and liver cancer, but it also must be acknowledged that a lot of people with chronic Hep C remain perfectly fine. So how can you tell? Well, what's interesting is when hepatitis C was first discovered, a lot of experts actually did not believe that hepatitis C caused disease. It took the French guy named Poignard to actually do the seminal study to prove that hepatitis C caused disease. How did he do it? He got a bunch of people, thousands of people, 2,235, and did liver biopsies on all of them. And he asked, how long have you had hepatitis C for? And what he observed was that the people who had the infection for longer had more scarring in the liver. So he concluded that hepatitis C over time, a very long time, caused cirrhosis, okay, at about 0.133 units per year. So if you get to 4, that's cirrhosis. So in general, they thought in 30 years, most people would have cirrhosis after 30 years of infection. Now, he also observed a bunch of other things which is not as well publicized. One is that the older you are when you get infection, the worse it is. And it's probably because your liver is an organ that can actually grow back. It's regenerating, but when you hit 40, your liver is no longer young and you can't grow back as fast anymore. Also, alcohol made a big deal of difference. Remember, this is a French study, so a lot of alcohol going on. So if you drink more than 50 grams per day of alcohol, which is more than 3.5 drinks per day, then your progression of disease went faster. And if you were a man versus a woman, men tend to do worse with hepatitis C. Okay? Now, at the same time, he also acknowledged that some people had hepatitis C for a very long time and did not have progressive liver disease. And these were typically women who had normal liver tests all the time. So this is a study out of the US, and I think in San Francisco, where they said, what are your ALT levels? So ALT is a blood test, which is a marker of how quickly your liver is being injured. Okay? So if your ALT levels are close to normal, a little bit up, and if you do biopsies over and over again, so the lower graph says that over many, many years, up to 12 years, people's liver disease actually did not get appreciably worse. Whereas if their liver enzymes were higher, much higher, so especially if the ALT was over 200, then the scarring happened very quickly. So hepatitis C affects different people differently. It all depends on how you yourself respond to the hepatitis C infection. So this is a liver biopsy, not for you guys, but in general. Okay? And the main reason why it's not for you guys is because you guys are hemophilia. The main risk of a biopsy is bleeding. So what this person is having done is a big long needle, about 10, 15 centimeters, stuck into the liver, and the liver is hidden behind the ribs, so you have to go between the ribs. Okay? And you all know if you're bleeding, one of the things you want to do is put pressure on it to stop bleeding, but you can't in this case because the liver is underneath the ribs, so you can't put pressure on it. Okay? So for everyone else, I would quote, it's not a very dangerous procedure. 1 in 5 people will have bleeding or bruising after it. The risk of serious complications is extremely rare, but people didn't like the thought of a big needle being stuck in their liver. So this is a procedure that's going out of vogue. Okay? I showed you the French study where they biopsied everyone. The other major conclusions from that study is, number one, people hate biopsies. It's true. And number two, what's even worse, is that a lot of times, 1 in 3 times, they didn't get enough liver out, so the biopsy was useless. Okay? And number 3, more importantly for Canada, is that most pathologists don't know how to look at a liver biopsy. So, for example, in my home province, Ontario, there's probably only 2 hospitals where they have pathologists that know how to look at the liver biopsy. Okay, so what can you do in 2015? Because you all know that there are new drugs here, so what should you do? Because a lot of people have been ignoring the hepatitis C. So I would say to you, it's time to stop ignoring the hepatitis C because there's a lot that's new. So the first thing to do is confirm that you really do have hepatitis C. Now, the hepatitis C test that we've been advocating for the last 20 years is actually the wrong test, right? Which is the antibody test. Antibody test is a screening test. It does not tell you if you have hepatitis C or not. If you're positive for the screen test, you must then do the PCR test. The PCR test looks for the virus directly, and you only have virus if the PCR is positive. So there are people walking around out there who think they have hepatitis C when they actually don't. Okay? So hepatitis C PCR test not only tells you if you have virus, but what family of virus you have. There are 6 major families. 3 of them are common in Canada, and the other 3 are from other parts of the world. So they're numbered 1, 2, and 3. So once you have confirmed that you have hepatitis C, the next thing is to ask, in me, myself, how quickly is the hepatitis C damaging my liver? So if my AST and ALT, my liver enzymes are very, very high, over 200, that's a bad sign. The liver is being damaged very quickly, and if your age is over 40, you can't sustain that injury for very long. Okay? Urgent for treatment. Whereas a lot of women in particular have persistently normal or almost normal ALT levels, and those people have barely any injury going on. Okay, and statistically, if you rebiopsy them over 10 years, there will be not much change. The majority of people have sort of these middling liver enzymes, between 60 and 120, and they will have slow progression of liver disease. So, given that you want to know how much damage there is, should you do a liver biopsy to see how much scarring there is? In the old days, we would have said yes, but there's a lot of newer technologies that can answer that question without a biopsy. So what are those? Well, believe it or not, a simple CBC is your best friend. Okay? If your platelet count is low, my apologies to the hematologists because they taught me in medical school that the most common cause was ITP. It's not true. So in a survey of adult men in the US, when you look at all comers with a low platelet count, the most common cause of a low platelet count under 150 is cirrhosis. Okay? It's cirrhosis. It's 60% is cirrhosis. So why? It's because when you have cirrhosis, blood has a tough time flowing through the liver. It starts to back up, and subtle increase in pressure in the spleen will make it hang on to platelets. So the platelets will start to fall. The other observation is that of the two liver enzymes, the ALT and AST, the AST starts to rise higher when you have cirrhosis. So someone came up with this extremely cheap test called the APRI, where you take the AST level and you divide it by whatever your lab normal is. So my lab normal is 40, but other places it's 60, 70, or 80. So let's say I have an AST of 82, my lab normal is 40, so 82 divided by 40, and then divide by the platelet count. So let's say my platelet count is 125. So if I do that calculation times 100, it comes out as 1.64. If you look at 1.64 on that graph, I don't know how to show the pointer, but, well, there it is. Let's say this is 1, that's 1.64. You can actually, just by those two tests, say that this is not F0 or a normal liver. It's possibly F3, but almost certainly cirrhosis. Okay, that's how powerful these two tests are. Simple CBC and an AST. I can even get even simpler and say to you, based on the fact that this person has hepatitis C and the platelet count is 125, there's a 95% chance they have cirrhosis, and that's all I need. Okay? Now, is this completely accurate? No, but it's about 80% accurate. Can we do better than that? The answer is yes. So remember the French guy who did a biopsy on everybody? He's a smart guy, and you guys, if you're younger, should learn from this, because he realized that people hate liver biopsies. So what he did was he took blood from all those 2,000 people and asked what blood test could possibly predict liver scarring. And he came up with 5 blood tests and 2 clinicals. One is age, the other one is gender. Then if you measure the bilirubin, haptoglobin, GGT, alpha-2 macroglobulin, and apolipoprotein A1. So hard to say, but those are tests you can actually get. Okay? You measure them, you come to his website, you put in your credit card number, he'll give you an answer. He's the man that destroyed liver biopsy in Europe in 2005. There's no more liver biopsies done. He's a multi-millionaire. Okay? Do we have it in North America? The answer is no. How come? It's because we come from Puritans who don't like the fact that he's making a lot of money. So it took a long time for us to adopt, but my home province now accepts this test as a surrogate for liver biopsy. You do not need a liver biopsy. It is 90% accurate compared to a liver biopsy, which means it is perfect, because a liver biopsy is wrong 10% of the time. Okay? So what are the disadvantages to this? Well, you have to do a blood test, and you have to put it into a calculator for this very complex equation. Can you find the equation anywhere? The answer is yes. So he had a grad student who wrote an article trying to say it's as good as a liver biopsy, and in the method section, they put in the formula. So it's available to all. It's on Wikipedia. Okay. So enter his colleagues down the road who said, he's making a ton of money. Is there anything else we can do? So the French love their wine and their cheese. So these were cheese eaters, and they realized that the cheese people had a new technology for telling how good their cheese was in terms of how hard it was. So this technology was knocking on cheese to see how hard it is, because if you just do a biopsy of a cheese, you can see what it tastes like, but you don't know its texture. So they realized that the liver is like cheese. If you knock on the cheese, you can tell how hard it is, and how hard it is how much scarring there is. So it turns out that this is probably the best test for liver disease, because it is the first test that tells you more than how much scarring there is. It tells you how bad the cirrhosis is. So let me put it into another way. The liver biopsy can tell you if you have cirrhosis, yes or no, but once you have cirrhosis, you have cirrhosis. The fibro test can tell you if cirrhosis or not, but once you have cirrhosis, it's cirrhosis. This can tell you if you have cirrhosis if it's early with low risk, versus if it's intermediate, higher risk of varices, versus high risk of liver failure. Okay, because its dynamic range is so huge. So anything under 6 or 7 is normal. Anything over 13 or 14 is cirrhosis. But once you hit 20, you're likely to have varices. Once you hit 30, you're likely to have ascites. The higher you go, the higher the risk of cancer. Very powerful. What does it look like? This is now an old machine. They've updated it. They're making a killing on this, because even though it's European and the euro has fallen a lot, they're still charging us over $100,000 for this machine. It is a simple computer with a probe, and all the probe does is it knocks. This is not as hard as this. That's it. Okay? But it does it in a standardized way, which is why it's $30,000. Okay? And then the computer tells you how hard it sounds. Now, it works perfectly if you've ever been to Paris. If you look like everyone else in Paris, which is this tall and skinny, it works perfectly fine. Okay? The problem is we're not in Paris. So if you're very tall or very big, you need another probe that's made for North Americans, which knocks harder. Okay? And kids, you have to have a smaller probe. So there's a small probe, a medium probe for the Europeans, and extra large probe for North Americans. There's actually no large probe. You laugh, but it's true. So in 2.5 minutes, you get a reading like this. On the far right is actually the raw data. The black line is the pressure wave going through the liver, and based on its slope, so how fast the pressure wave goes through the liver, you can tell what it sounds like, you can tell how much scarring there is. It is an amazing test for telling you how hard the liver is. So for example, for the doctors, if you have anyone with amyloid, you can actually tell how much amyloid is in the liver by doing this test. Okay, so that's a technology we have now for telling you how bad is your liver. My next part is to tell you about what's new for the drugs. And part of this comes from how we realize hepatitis C gets into the cell and how it replicates, how it's a single-stranded RNA which makes all these proteins. You don't really care about that. What you need to know or are interested in is that we've gone through a lot of treatments that are now historical. Interferon we've been using since the early 1990s. Ribavirin came in 1998. Boceprevir and telaprevir, which we thought would save us in 2011, turned out to be terrible drugs. Lots of side effects, especially if you had cirrhosis. People were dying from the drugs itself. Enter 2013 when we had Cimeprevir, and then at the end of 2013 also Sofosbuvir. Then people were scandalized because this is the pill that costs $1,000 US per pill, but it was only 655 Canadian up here. So believe it or not, I would class these two as also obsolete. So where are we now? The current drugs in 2015, this is from the most recent Canadian guidelines, and I warn you, for those who love guidelines, is that it is out of date. Okay, the field is moving so quickly. So I showed you that telaprevir and boceprevir were the first two protease inhibitors. It's gone. Last year, what was very in vogue was to use Cimeprevir and Sofosbuvir together as an off-label treatment. So ironically, Health Canada has now approved it as treatment. It is obsolete. Okay? Why is it obsolete? It's because we have better stuff that's cheaper, works better, less side effects. Who wouldn't want that? So the big players right now in 2015 are Sofosbuvir and Ledipasvir, that so-called Harvoni, and then something else that's more complicated, Paritaprevir, Ombitasvir, and Dasabuvir, which is the Hokura pack. What else is out there? We have Sofosbuvir Ribavirin, the Cladisvir is coming at the end of this year, and we still have PEG interferon Ribavirin. So there's different options, but better drugs for most people. Now, here's the part where I normally would show you all the studies that came up with these recommendations. I'm not going to do that because they all look the same. Okay? How do they look like? You get a bunch of people with hepatitis C, up to 15% have cirrhosis, right? All of them are the least cirrhotics that you can ever find. They're completely asymptomatic. Their platelet count's well over 90. You treat them with whatever drug combination you want for 12 weeks. They have no side effects, and almost all of them are cured. That's it. Every single study is saying the same thing. That has now become the minimal standard for which we judge all studies, that if they can take the drugs and the cure rate's over 90%, we pay attention. If it's under 90%, it's not worth looking at. Okay? And the side effects have to be nothing. It turns out that for most of these studies, the biggest reason that treatment fails is because they didn't take the drugs. Okay? All right, so this is where we are at in the hepatitis C field. You may not know this, but in Toronto we have a major meeting going on. We have all these experts from Europe, and the state-of-the-art lecture yesterday, Michael Mann said what I've been saying, which is hepatitis C, it's over. The time for research is over. It is now time to translate and treat people. The study cycles have completely shortened. We used to treat people for a year. We now treat people for 12 weeks, sometimes 8 weeks. Health Canada has completely surprised us because we're all so cynical. We always say the Americans get it before we do. It's not always true anymore because some drugs we've actually gotten in Canada before the Americans, and a lot of these drugs we've gotten after the Americans within a week, maybe two. So they're happening very fast. Then the next cynical observation is that your provincial agencies may not fund these medications, but I don't know about across the country. I think Yukon was the first to fund it, and Ontario came a few weeks later. So they're actually paying for the stuff. Okay? So my last disclaimer to you is that the data I'm going to present to you is current as of EASL 2015, which is the European meeting in April. But by November 2015, whatever I tell you is going to be obsolete. Okay, so what am I currently doing for my patients with hepatitis C genotype 1, which is by far the most common cause of hepatitis C in Canada? Harvoni. So fosbuvir and ledipasvir, single pill, one pill once a day. The toughest thing about this is remembering to take your pill every day, and that's nothing to be sneered at, right? Because the adherence rates for things like blood pressure pills, cholesterol pills, is about 70%. That will not do for these pills. You have to take it every day. So that's what I stress with my patients. It is safe for most people, but there's a caution if they have renal failure before dialysis. It might make renal function worse, so you might shove someone into dialysis requiring. It is still expensive, so the full price is $67,000. Some people can get away with 8 weeks of therapy instead of 12 weeks of therapy if they're so-called easy to treat, so if they've never been treated before, if they don't have cirrhosis, and their viral load is relatively low, less than 6 million. How well tolerated? This is where it's very, very funny, because I treat people who are very sick, and they say, this is a breeze, there's no side effects. Then I turn around and take someone who's completely well, right? They don't take medications, and they complain. Headaches, they're tired. It seems to be worse in the first 3 or 4 weeks, and it's not like terrible headaches and fatigue that we had with interferon, but they notice it. The other thing that's been funny that our patients have been telling us is that some people's appetite has gone up a lot, so they're eating. Their energy level has gone up, and their sex drive has gone up. Enough that they're complaining, which is interesting. Okay, so the other drug that's available is more complicated because more drugs, but it's not terrible. Okay, this is paritaprevir, ritonavir, ombidisvir is one pill, dasabavir is another pill, and you may or may not have to use ribavirin. So there's more pills, there's more potential for drug-drug interactions, but the bonus is that it's cheaper, so it's $56,000. So you say that's still ridiculous, but it's not true for everyone. Let me give you some examples. I have quite a few patients who are desperate for treatment before the government was paying for it. They had no confidence in our provincial government to pay for these drugs, so they fundraised. They got their friends together, they raised money, and this was easier to reach for them. So they're on this medication. But it is more pills, and there's more room for that you have to worry about drug-drug interactions. The other thing is that it seems to be safer if you have some degree of renal insufficiency. So if your creatinine is 200, you might want to go with this rather than Harvoni. Okay. The last thing I want to show you is some special groups, because with interferon, we said that there were special groups that either were too sick, too dangerous to treat, or it was too complicated to treat. And one of them are the people who are in your local hospitals who are dying of liver failure. Okay? So you need to know that in 1998, we had the same situation with hepatitis B, and along came 3TC or lamivudine, and all those people left the hospital. They're now fine. So this is where we are now with hepatitis C. So Harvoni or sofosbuvir, ledipasvir has been tried in people with liver failure pre-transplant. I'm just going to skip through it. The cure rates are just under 90%. I told you to ignore stuff under 90%. The reason why it's under 90% is because this is a very, very sick group. And the people stopped taking it because they died. They're too sick. Okay? So these are the people that are on the verge of salvageable, and I think it's worthwhile salvaging them, because look at this. The blue lines show individual patients who improve clinically, either by Child-Pugh score or MELD score, which is huge. A Child-Pugh score improvement is a dramatic improvement in symptoms. a dramatic step back from liver failure. Does it happen in everyone? No, because there are some orange bars showing that liver disease actually gets worse on treatment. But for the majority of people, they had real improvements in liver failure. We don't have long enough follow-up because these drugs haven't been out long enough, but it's hoped that it will be like Hep B. Hep B, just so you know, hardly anyone with Hep B ever goes for a transplant anymore. Okay? Currently, Hep C is the most common cause for a liver transplant, and it's my hope that in 3 years, after we transplant everyone, there will be no more Hep Cs listed for transplant. So that's where we are. There's more on the way. So Harvoni is an amazing drug, but believe it or not, it's not perfect. It doesn't cover, say, genotype 3. So Gilead's already working on what I call the son of lidiposphere, GS5816. So even though it's been approved in 2014, it will likely be obsolete in the next few months to a year. Merck is getting into the game. Their drugs now have names, Ribavirin and Elbasvir. And AbbVie, the makers of Hulkira, know that their drugs are a little bit too complicated, and they also have new drugs in the pipeline. So the development is still happening. So given all that, what's my approach? I say anyone with abnormal ALT or a low platelet count should be tested for hepatitis C. Okay? The screening test is an antibody test, but a confirmation test is the PCR. For you guys, it's all because of blood products, but the other risk factors for injection drug use just once is associated with a 50% chance of Hep C infection. If you come from an endemic country, so Egypt, Vietnam, and believe it or not, south of Italy, anyone in their 70s, there's a 1 in 3 chance they have hepatitis C because of healthcare practices. Once you have a positive antibody test, confirm it with PCR. Once you confirm the PCR, assess how much fibrosis is with one of those new tests. You can do an APRI, fibro test, or FibroScan, and then consider treatment. Okay, so this is my opinion now. I've given you data. There's so many people with Hep C out there. We have to prioritize, or at least I do. I literally have thousands of patients. So who are we urgently targeting for treatment? It's the sickest people with liver failure in hospital. It's the people with liver cancers who are under control, okay, because we know getting rid of the virus will actually decrease the risk of recurrence of cancer. Very rarely, hepatitis C can cause a vasculitis, so those people are very urgent for treatment. And those people with cirrhosis or close to cirrhosis are urgent for treatment. Everyone else, believe it or not, can wait. But there's another group of patients that we in the past would say don't treat because they've got other baggage going on. So if they're alcoholic, if they have bad diabetes, we now recognize that the two diseases together is worse than Hep C alone. So it's hoped that getting rid of Hep C will actually prevent liver failure. So the alcoholics, the diabetics, the ones who are rapidly progressing because of high enzymes. And also, some people need drugs that are potentially damaging to the liver so that you can actually get rid of the Hep C before that happens. The other people that we can sit on or wait are the people with minimal disease, or if they have other things that are more problematic. So if you have a bad heart with congestive heart failure, your heart disease is more important than your liver disease. So you have to look at everyone individually. Okay? So what's happened for my practice? In 2013, 2014, I barely treated anyone. How come? Because we knew the drugs were coming. Why would you give them terrible, terrible drugs? So we actually stopped treating. Since October, I have treated, this slide is out of date, about 150 patients already. Since October, okay? And we're treating inpatients. So can I back this up? We have electronic medical records since 2006. I actually know that we have 3,883 Hep C patients to deal with, of which some of them it's too late. Cancer in 208, 22 transplanted, and 89 have already died. Okay, they're not great stats, but it's, on the overall scheme of things, we still have a ton of Hep C patients. So where are they? In our cirrhotics, we've already cured 252 over the years, but we have 88 cirrhotics on treatment, and we have another 1,066 to go. For our non-cirrhotics, I have 1,686 to go. And my personal goal, because I treat HIV as well, is that all of my HIV co-infected patients will be treated by the end of this year. And that all of my cirrhotic patients will be treated by the end of next year. And I think it's doable. So I'm going to close with this slide. This is a slide from Rob Myers from the Canadian Consensus, looking at the estimated burden of hepatitis C. And in particular, if you look at the projection for cirrhosis in Canada, it continues to go up. Okay? And the reason why they say that is because they think that there's a lot of people with cirrhosis that don't know it, or hepatitis C that don't know it. So I can't help them if they don't know it. All I can say is for my patients, I pledge this will not happen to my patients because we'll cure them.
Thank you so much. We're 5 minutes over. I'm looking at David, but we started 5 minutes over. Is there time for one or two questions? Anyone? So I'm wondering if right now with these asymptomatic ones that you could say that you don't think they're going to progress over many years, can they get the drug if they're totally preoccupied with?
Okay, thanks for that. So asymptomatic means you're not sick. The problem is you don't know how much scarring you have, so you actually need to be assessed for scarring. So the vast majority of people with cirrhosis or almost cirrhosis have no symptoms. And I think those are probably the most urgent to treat to prevent liver failure or cirrhosis and the risk of cancer. The people with very minimal disease, I mean, they have the luxury of time. They have the luxury of making a choice because everyone's an individual. Other people have different things in their lives that might be a priority. They might be going to school, work might be very stressful, home might be very stressful. And a lot of people do elect to wait. But you can get treatment, but it depends on how you want to pay for it. So the very, very rich patients will pay cash, huge discount. People with a drug plan, some drug plans are paying for it, but not all of them are. If you have the compensation package, they will pay for it, I believe. But if you're waiting for provincial funding, like provincial formularies to pay for it, I know in Ontario they will not pay for it if you have minimal disease. So no fibrosis at all, they won't pay for it.
Just to pursue on that note, people who are in 86 to 90 compensation plan will get payment. And there are no conditions attached to it. So if their province is not paying up front or they don't have a private plan to pay up front, it will, the compensation plan will pay, but only after the fact. And so you saw the price. So we have worked out a deal with both AbbVie and Gilead for them, there'll be a patient assistance program who will pay up front and get reimbursed once the compensation plan pays the patient. So there are no barriers to treatment for those who are in the 86 to 90 program. The pre-86 post-90 is more complicated. There is money out there, and we're trying to make sure it gets freed up for those patients who are in that program.
Yeah, for those people on the plan, it's almost like you have too much choice. So what I would say to you is really sit down with your healthcare provider and decide what is the right treatment for you. Okay, because there are 6 genotypes, and everything I've just been telling you is mainly genotype 1. There are the other genotypes where the treatment's going to be different. And I would say to you, ask them this key question. Number 1, side effects. Number 2, do you expect my cure rate to be over 90%? And if it's not, would I be better waiting? And right now, for genotype 3 specifically, you actually might be better off waiting than treating right now if you don't have advanced fibrosis.